All right, so let's dive into something
Okay.
that I think is pretty crucial for anyone who's managing rheumatoid arthritis patients.
Yeah.
And that is stroke risk.
Mhm.
We're all aware of the usual suspects when it comes to stroke risk.
Right.
Things like age and smoking and high blood pressure.
Of course.
But the thing that's really interesting here is that
Yeah.
rheumatoid arthritis itself appears to be an independent risk factor for stroke.
Absolutely.
We're talking about a 1.5 to 2-fold higher risk of stroke.
Wow.
And that's even after adjusting for those traditional risk factors that we just talked about.
So independent of those other factors.
Independent.
Okay. Interesting.
So today we're going to try to break down what this means for you and your patients.
Okay.
And we're going to be pulling some insights from a couple of really interesting articles.
Okay.
The first one is called Cardiovascular Complications of Rheumatoid Arthritis.
Mm-hmm.
And that's from Current Opinion in Rheumatology.
Yep.
And the second one is called Stroke Risk in Rheumatoid Arthritis Patients, Exploring Connections and Implications for Patient Care.
Okay.
And that's from Clinical and Experimental Medicine.
Got it.
So it's definitely something to have on your radar
Oh, for sure.
with every single RA patient you see.
Absolutely.
Mhm.
I think, one of the things that makes it really challenging is that the underlying mechanism isn't as straightforward as we might think.
Right. It's not just about plaque buildup in the arteries, although that's definitely a part of it.
Right.
So what else is going on here?
Well,
What is it about RA that seems to increase the risk of stroke?
I think
Never.
chronic inflammation is really the key player here.
Okay.
We know that it's a hallmark of rheumatoid arthritis, but it's also increasingly being recognized as a major driver of atherosclerosis
Okay.
and a whole host of heart complications.
So inflammation is sort of the common enemy here,
Exactly.
but how does inflammation in the joints actually translate into a higher risk of stroke?
Yeah, that's the question, isn't it?
Yeah.
I'll think of it this way.
Okay.
Those inflammatory cytokines,
Right.
like TNF,
Okay.
IL-1, IL-6,
Yeah.
they're not just hanging out in the joints.
Right.
They're getting into the bloodstream and they're wreaking havoc on blood vessels,
Okay.
contributing to that atherosclerosis that we talked about.
So it's like a chain reaction
Yeah.
that starts in the joints
Mm-hmm.
and ultimately impacts the cardiovascular system.
Exactly. It goes beyond just the blood vessels, though.
Oh, really?
Yeah, RA can actually damage heart valves,
Wow.
increasing the risk of atrial fibrillation,
Oh, yeah.
which, of course, is a major stroke risk factor in and of itself.
Huge.
And there's even emerging evidence of subclinical myocarditis,
Okay.
which is inflammation of the heart muscle
Interesting.
in some RA patients.
We're talking about inflammation impacting the heart on multiple different levels, which obviously raises concerns about heart failure.
Absolutely. And this is where I think recognizing heart failure with preserved ejection fraction, or HFpEF,
Okay.
becomes particularly important in RA patients.
And that's because it might not show up on those standard measures of heart function.
That's exactly right.
Okay.
You could have a patient with a normal ejection fraction.
Right.
But that underlying inflammation could be silently contributing to heart dysfunction.
Oh, wow.
And I think this really highlights the need to be extra vigilant in monitoring these patients.
Absolutely. So we're seeing how inflammation can really set the stage for all sorts of cardiovascular issues, including stroke.
Right.
But the research also points to RA severity itself as a risk factor.
Yes, it's not just about those traditional risk factors. Higher disease activity is directly linked to a greater strain on the heart,
Okay.
which can manifest in several ways.
Like what?
Well, for example, one study found a clear association between RA activity and increased left ventricular mass.
So the more severe the RA,
Yeah.
the harder the heart has to work.
Yes, and there's growing evidence that looking at global longitudinal strain,
Okay.
which is a more sensitive measure of heart function,
Right.
can give us an even earlier indication of potential problems.
Interesting.
One study showed that impaired strain in RA patients was a predictor of both heart failure and myocardial infarction.
So if we're seeing those subtle signs of dysfunction, that should be a red flag for us.
Absolutely. It's a call for early intervention.
Yeah.
And this is where being proactive is absolutely crucial.
And that brings up the question of how we actually identify those RA patients who are at the highest risk of stroke.
Right?
I mean, do we need specific tools beyond just the general stroke risk calculators?
I think you're thinking along the right lines.
Okay.
There are definitely some specific tools emerging that are proving very helpful.
Like what?
Well, the anti-CCP2 test, for example, is
Right.
already used in RA diagnosis.
Mm-hmm.
But research is showing a strong connection between positive anti-CCP2 results and increased stroke risk.
And This is especially true in younger patients, right?
Yes, that's a key finding.
Okay.
So if you have a younger RA patient
Yeah.
with a positive anti-CCP2, that's a definite signal to pay close attention to their cardiovascular health.
So it's an opportunity to be proactive and potentially intervene earlier?
Exactly.
Okay.
And then there's the multi-biomarker disease activity score, or MBDA score.
Okay.
This uses 12 biomarkers
Wow.
to give us a much more detailed picture of RA disease activity
Oh,
than
yeah.
just counting swollen joints.
It's like we're getting a deeper look under the hood.
Precisely. And the research is showing a clear link between higher MBDA scores and a greater risk of cardiovascular events,
Including stroke.
including stroke.
Okay, hold on. Before we jump into that,
Sure.
let's just make sure our listeners don't miss this.
Okay.
That MBDA score, if it's high, means that we need to be thinking about stroke risk even more seriously for that patient.
Absolutely. And the really exciting thing about the MBDA is that it goes beyond just assessing disease activity. There's actually a new CVD risk score specifically for RA patients based on the MBDA.
Oh, wow.
This score incorporates traditional cardiovascular risk factors with these biomarkers of inflammation
Okay.
and can predict the likelihood of major events like heart attack and stroke within the next 3 years.
That's incredible. It really gives us a roadmap for personalized care.
Exactly. And it brings us to, I think, a crucial question. How do we take all of this knowledge and translate it into effective management strategies for our RA patients?
Right. We've established that RA is an independent risk factor for stroke.
Yes.
And we have these tools like the anti-CCP2 test and the MBDA score to help us identify high-risk individuals.
Right.
But what does that actually mean for treatment?
Well, it means that aggressive treatment for RA inflammation is paramount to reducing overall cardiovascular risk,
Including stroke.
including stroke.
Okay, so we're not just managing symptoms.
Yeah.
We're aiming to control that root cause of inflammation as effectively as possible.
Exactly. And that often means utilizing DMARDs,
Okay.
like methotrexate and TNF inhibitors.
TNF inhibitors, though, have had a bit of a controversial history when it comes to heart health, haven't they?
You're right. There have been concerns about their potential to worsen or even trigger heart failure in some patients.
So how do we reconcile those concerns with the need to control inflammation?
I think it comes down to careful patient selection and meticulous monitoring.
Right.
For patients with pre-existing heart conditions, particularly heart failure, TNF inhibitors require extra scrutiny.
Mm-hmm.
We need to carefully weigh the potential benefits of reducing RA inflammation against the possible risks to their heart health.
So it's a balancing act.
Precisely, and even in patients without pre-existing heart issues, vigilance is key.
Okay.
Regular monitoring of cardiac function using echocardiograms and cardiac MRI is crucial to catch any early signs of dysfunction.
And if we do see those signs,
And we adjust our strategy accordingly. That might mean switching to a different type of DMARD or adding medications to manage heart failure.
are there other types of DMARDs that are considered safer for the heart
Yeah.
compared to TNF inhibitors?
Research is ongoing, but some studies suggest that non-TNF biologics such as IL-6 inhibitors
Okay.
may have a more favorable cardiovascular risk profile.
And that's because they target a different inflammatory pathway.
Exactly. IL-6 inhibitors block the action of interleukin-6,
Uh-huh.
another cytokine heavily involved in RA inflammation.
So by hitting a different target, they might reduce inflammation without the same potential downsides for the heart.
That's the theory, but more research is needed to fully understand the long-term cardiovascular effects of these newer DMARDs.
We've talked a lot about DMARDs,
Right.
but what about NSAIDs?
Yeah.
I mean, they're commonly used for pain relief in RA,
Sure.
but what are the implications for stroke risk?
That's a good question. The research on NSAIDs and stroke risk is a bit mixed.
Okay.
Some studies have suggested that certain NSAIDs, particularly COX-2 inhibitors,
Yeah.
might be associated with a slightly increased risk of stroke.
QX2 inhibitors had those high-profile concerns about heart attacks, right?
Yes, and those concerns extend to stroke risk as well.
Okay.
But it's important to remember that not all NSAIDs are created equal.
Right.
Some studies haven't found an increased risk with other types of NSAIDs,
Okay.
and some have even hinted at a possible protective effect.
So it's not a clear-cut answer.
Right, it highlights the importance of individualizing treatment.
Yeah.
We need to be aware of the potential risks and benefits of NSAIDs for each patient,
Okay.
especially those with a history of cardiovascular disease or other stroke risk factors.
So use them judiciously and for the shortest duration possible.
Exactly. And speaking of inflammation and its far-reaching effects, there's another factor that I think warrants discussion:
What's that?
substance P.
Substance P? I'm not familiar with that one.
It's a neurotransmitter involved in pain signaling and inflammation.
Okay.
It's found in higher levels in the joints of RA patients and might actually contribute to the inflammation and joint damage.
So it's another piece of the inflammation puzzle.
Yes, and what's interesting is that elevated substance P levels have also been observed in patients who have had a stroke.
So could substance P be a link between RA and stroke?
It's a possibility that researchers are exploring. The exact role of substance P in this context is still unclear.
Okay.
But it highlights the complexity of these interactions. Uncovering these mechanisms could pave the way for new targeted therapies, not just for RA symptoms, but also for reducing cardiovascular risk.
That would be an incredible breakthrough.
Absolutely. But even without those targeted therapies, I think the key message here is that we need to approach RA with a holistic perspective.
Okay.
We're not just treating joints.
Right.
We're treating the whole patient, and that includes their cardiovascular system.
That's a great point.
Yeah.
RA is more than just a joint disease.
Right.
It's a systemic condition with far-reaching implications.
Exactly. And this deep dive has really highlighted the need to be thinking about cardiovascular risk from the moment an RA diagnosis is made.
It's about being proactive, vigilant, and using all the tools at our disposal to identify high-risk patients.
Yes.
And tailor treatment strategies accordingly.
Couldn't have said it better myself. It's an exciting time to be in medicine with new discoveries happening all the time.
Don't forget to check out the show notes for links to the research articles we discussed today.
And as always, if you found this deep dive valuable, please share it with a colleague. You know, we're seeing a real push towards personalized medicine,
Okay.
using biomarkers and genetics to refine our understanding of individual risk and tailor treatment strategies accordingly.
Okay, let's unpack that a little bit.
Sure.
We already talked about the anti-CCP2 test and the MBDA score as being valuable tools
Right.
for assessing risk, but what's on the horizon in terms of biomarkers?
Well, researchers are actively investigating new biomarkers
Okay.
that could give us even more granular insights into a patient's cardiovascular risk profile. For example, certain blood proteins that are associated with both blood clotting and inflammation
Okay.
are showing promise as potential predictors of stroke risk.
So we're talking about identifying those tiny molecules that might hold the key to understanding who's most vulnerable.
Exactly. And if we can identify those individuals early on,
Yeah.
we can intervene more aggressively,
Okay.
potentially even preventing stroke from happening in the first place.
That's the ultimate goal. And what about genetics?
Yeah.
Where does that fit into all of this?
Genetics is another exciting area of research.
Okay.
We know that certain genes can increase susceptibility to developing RA,
Right.
and some of those same genes might also influence stroke risk.
So it's like a double whammy for some patients.
In a way, yes, but the good news is that understanding these genetic links could lead to highly personalized treatment approaches.
Okay.
Imagine being able to tailor DMARD selection or the intensity of monitoring
Yeah.
based on an individual's genetic profile.
That's the power of personalized medicine, right? Getting the right treatment to the right patient at the right time.
Exactly. And it's not just about predicting risk. It's about potentially modifying the disease course itself
Okay.
by targeting specific genetic pathways. That's where the real game changer lies.
It sounds incredibly promising.
Yeah.
But let's step back from the future for a moment
Okay.
and talk about what we can do right now.
Sure.
I mean, we've talked about DMARDs.
Right.
We've talked about NSAIDs.
Yeah.
Are there any other strategies that can help us manage RA and reduce stroke risk?
Absolutely. Beyond medications.
Yeah.
Lifestyle modifications play a crucial role.
Okay.
We know that factors like diet, exercise, and smoking cessation can have a significant impact on cardiovascular health.
Right.
And that's especially true for RA patients who are already at increased risk.
So it's about empowering patients to make those healthy choices.
Exactly. And there's growing evidence that those lifestyle changes can also positively impact RA symptoms.
Oh, wow.
So it's a win-win situation.
Yeah. Okay. And what about new treatment modalities? Are there any exciting developments on the horizon?
Definitely one area that holds immense potential is stem cell therapy.
Stem cells, that sound like something out of science fiction.
It might sound futuristic, but the research is advancing rapidly.
Okay.
The idea is to use stem cells to repair damaged joints,
Okay.
essentially resetting the immune system and halting the progression of RA.
So if we can stop the RA in its tracks, then we also eliminate the long-term complications.
Yes.
Including stroke.
Precisely. It's still early days, but the initial results are encouraging.
It sounds like there's a lot to be hopeful about in the future of RA treatment.
I agree. We're moving towards a more personalized, targeted approach
Yeah.
that focuses not just on managing symptoms, but on tackling the underlying causes of the disease.
Well, this has been a truly enlightening deep dive.
It has.
We've covered a lot of ground.
Yeah.
From the inflammatory underpinnings of RA to the complex interplay of risk factors
Right.
and this promising future of personalized treatment.
It's been a pleasure exploring these topics with you.
As we wrap up, I think the most important takeaway for our listeners is
Okay.
RA is not just a joint disease.
Right.
It's a systemic condition with far-reaching implications.
Yeah.
And cardiovascular risk, especially stroke risk, needs to be a top priority from the moment of diagnosis.
Couldn't agree more. And as we've discussed, we have an expanding toolbox to help us identify high-risk patients and personalize their care, which is really empowering.
So being proactive, vigilant, and staying informed about the latest research is key.
Absolutely. By working together and embracing a holistic approach, we can make a real difference in the lives of those affected by RA.
Well said. Thanks for joining us on the deep dive.
It's been a pleasure.
Disclaimer and bibliography in the description. And if you found this deep dive valuable, we encourage you to share it with a colleague. Let's keep the conversation going and continue to improve patient care together.